Hello, my name is Roseanne Vitale, and I will walk you through the prosection of a pig kidney. And we'll talk about some of the anatomic differences that you will notice in the specimen. What we are looking at is the outside of the pig kidney with attached adipose tissue, which is referred to as perinephric fat in the human specimen. The fascial plane that encases that perinephric fat and kidney is referred to in the human specimen as gerotis fascia. While it looks quite different in the pig kidney, you can hopefully appreciate the adipose tissue and the smooth, glistening layer covering that adipose tissue that encases your pig kidney. The next thing we'll talk about is the orientation of the pig kidney and the human kidney. The human kidney orientation is such that the renal vein is the most anterior structure, the renal artery is posterior and slightly superior, and the ureter courses caudally and is the most posterior structure. So we'll go ahead and look at those hilar structures on this pig kidney. What you can see here is a very thin-walled vessel right here. So this is our pig renal vein. I would like you to note that I did dissect this particular renal vein. It was much longer and in a strip. Remember that the right renal vein empties immediately into the inferior vena cava. So in this particular case, this is a right renal vein. So I did have to dissect off the directly adjacent inferior vena cava in the pig. The next structure that we will identify is the renal artery, which is much more thicker and muscular. And I'll just go ahead and kind of probe that for you here. All right, so you can see where it enters into the kidney there. So that is your renal artery. And then what you'll do is sort of palpate the adipose tissue to find your ureter. I'm just going to set this down so I can probe it a little easier. So I'm palpating, and I will lift this up again just so that you can see it. You can hopefully appreciate that delicate, thin mucosa present within this lumen here, which I will now probe. And that is our ureter. Okay. All right. An additional unique feature that you need to be aware of on the pig kidney is their adrenal gland, which I'll remove my probe. You can see here. Remember, in the human, the right adrenal gland is more pyramidal in shape, and on the left adrenal gland is more crescent shaped and medial. So what you are going to do is dissect off your adrenal gland and set it to the side, and we'll save it for a future lab. All right. So when we receive a kidney specimen, make sure that we weigh the specimen. We measure the entire specimen in 3 dimensions and measure our hilar structures in length and diameter. I am now going to ink my hilar structures. I have now inked several pertinent structures. Prior to beginning a kidney prosection, it is imperative that you review the patient's imaging and clinical history to determine if renal vein involvement of tumor was identified. You will need to look in the renal vein to determine if tumor is present and make sure that you document it with your gross description and with a section submission. Another thing that you will do upon receiving a nephrectomy specimen is palpate the specimen to determine where the mass is. This also should have been noted when reviewing the imaging. So I am saying that there was a mass in the superior pole, which is a common area for renal cell carcinomas to be found. I have then inked the gyrotous fascia over the palpated mass, and I've also inked my hilar structures. Again, you can see the thin-walled renal vein, which I have applied green ink to. I've also applied green ink to my renal artery. Remember, this is a thicker walled structure. And the caudally coursing ureter. So after you have inked those structures, examined them for tumor involvement, you are then going to place a probe into the ureter and use that as a guide for your prosection so that you may cut the specimen from a hilar approach. Before doing that, I am actually going to take my scissors and cut along the ureter to also ensure that there is no tumor present in the ureter. I am now cutting along my ureter with scissors to determine if any tumor is present. You can appreciate the longitudinal folds of the ureter mucosa itself. And remember that the outer layer of the ureter is adventitia, so it is a true margin. Okay, at this point you may also shave your hilar vessels. One way to do that, I've looked at my ureter, there's no tumor, so I'm definitely okay to shave this margin. So in this particular case, I'm just going to use my scissors and I will place the ink face down into the cassette. I'll leave my probe into my ureter here. Next, I will shave my renal vein, and same thing, I can just use scissors to carefully remove the renal vein margin. In this particular case, there's no concern about tumor present. Remember, the tumor has to be invading into the vessel wall in order for it to be considered a positive margin. If the tumor is simply bulging into the renal vein, that is not considered a positive margin. You can see my cutting into my artery a little bit there. I'm just going to carefully. Okay, so now I have my renal vein margin, which I will submit, ink down, en face. Hopefully you can appreciate that. And now we can look at our renal artery. It doesn't look like there's any tumor present here. I'm going to shave this one as well. And I will submit that en face. Okay. All right. So now comes the next step, which is using the probe as a guide for my blade to ensure that I am in the renal pelvis. I am using a medium blade, and I will cut towards from the hilum towards the renal pelvis. This approach is useful for tumors that originate in the renal parenchyma, such as a renal cell carcinoma. However, there is such a thing as an anti-hilar approach. Some people will actually place the probe all the way through the kidney so that you're ensured that you've gone through the renal pelvis, and then you'll actually cut towards the hilum. That is called an anti-hilar approach. And that is something that typically can be done for tumors that originate in the epithelium of the ureter and renal pelvis. So now I'm going to begin, and so basically what I'm doing is holding the ureter up with my probe so I can be sure that I can visualize it as I'm cutting. And I want to really make sure that I'm in that renal pelvis. You can see where my probe is located, hopefully. And try to avoid go. Okay. Let's finish this cut. All right. So what you can see here, and I'll just lift it up so you can see it a little better, is that you have urothelium on both sides, so that nice pink tan, glistening mucosa. Okay, you have this is your renal pelvis. You have your major calyces and your minor. Okay, this is your cortex, the medulla, and obviously these look a little different than the human specimen, but remember the medulla is pyramidal in shape. Okay, so now at this point, once you've bivalved the kidney, what you can do is measure the kidney in 3 dimensions, because remember we had all that additional adipose tissue attached. And then at this point in the human specimen, you want to identify your adrenal gland as well. And this we don't remove. You never remove an adrenal gland in a human specimen prior to cutting open the specimen. All right. Okay, now I have created a lesion in my superior pole. Remember that clear cell renal cell carcinoma has a very distinct yellow tan feature, and that's due to cytoplasm rich with glycogen and lipids. And they tend to be in the superior pole, which is what I have done here. So the next thing you'll do typically is fix your specimen, and you can do that after sectioning. One thing about sectioning I'd like you to keep in mind is that one of the most important sections you will take is your tumor in relationship, and in the pig it's this white tan adipose tissue, is that renal sinus fat. So that is all the adipose tissue that is basically housed within and underneath your renal pelvis mucosa. Invasion into renal sinus fat is associated with a poorer prognosis and needs to be documented not only in your gross description, but represented with the cassettes that you submit for permanent section. So due to the friable nature of renal cell carcinomas, it is important that you do allow your specimen to fix so that you don't accidentally transfer tumor cells to uninvolved areas. So one thing you may want to do prior to sectioning is at least cut in a fashion, so in sort of almost like a fan fashion, so that you can at least maintain the relationship of your tumor to that renal sinus fat. Now remember, the kidney has now 2 sides because you've cut along the renal pelvis into 2 halves. So what you'll need to do is, of course, measure the tumor, but you need to make sure that you're including the both halves together. So after you cut and determine the greatest extent of that tumor within the renal parenchyma, remember this is not a depth of invasion. We are not invading deep into this parenchyma. The tumor originates in the parenchyma. If it was originating in the epithelium and invading down through layers, then you would have a depth of invasion, but in this case, it's not a depth of invasion. You're just measuring the greatest of 3 dimensions of the tumor. The next thing you'll want to ensure that you do prior to doing any further cutting and sectioning is measure your cortical thickness. So you can see I have my medulla here, and you'll want to measure and kind of make sure you get an average thickness of your cortex. And you can also get your cortical medullary thickness as well. So then in this case, I'm just including my cortex, so it's 1.1 centimeters. And if I was going to include my medulla, that would be 2 centimeters. Okay, so it's much easier to determine the cortical medullary junction in a human kidney specimen than it is in this particular specimen. Okay, so then you are going to serially section the specimen prior to allowing it to fix. In this particular case, I'm going to make a cut here so that I can take a section of tumor in relationship to my renal pelvis and to my renal sinus fat. Another measurement you want to take after sectioning is the distance to the capsule. Well, in this particular case, you can see this orange ink up here, so it's abutting the capsule. And then you want to measure the distance to that Gerota's fascia, which is that blue inked margin. And so you can do that after sectioning. Let's see if I can do it on this half for you. Okay, so now I've cut through. Okay, and let's say that the tumor extends maybe to about here. I'll just make it look like it's about there. So then I would measure the distance to Gerota's fascia, of course, wherever it's closer on either side. So in this case, we have 1 centimeter to Gerota's fascia. Okay, remember again that you would make sure to document if the tumor is directly involving your adrenal gland, or if when you section through the adrenal gland, there's a discontinuous tumor, as this changes the staging from a T4 if it's a continuous spread, meaning say right here was my adrenal gland. If the tumor was spreading directly into it, that would make it a T4. However, if there was kidney parenchyma, let's say over here, if you had normal kidney parenchyma and then your adrenal gland, and then there was a lesion in the adrenal gland, that's discontinuous, and that would be considered a M1 metastasis. Okay, so then you are going to section the remaining kidney parenchyma at 0.5 to 1.0 centimeter intervals. Remember, take your blade, try to make nice smooth cuts. Kind of let the weight of the blade do the work for you. Okay, you want to describe the uninvolved parenchyma, any secondary pathologies, cysts that you may identify. All right. And now we will go through our sections. So we'll say that we fixed our specimen for a couple of hours, and now we're going to go ahead and section our specimen. So the first thing you want to do is use a clean blade and take a representative section of your uninvolved. I think that's the best way to go about it, so that you're not actually sectioning tissue that has tumor on it first. So I'm just going to go ahead right here and get a sample of my cortex and my medulla. What I'm trying to do here is just take a thin section to begin with, so that I do not have to go back and trim. Okay, so you can see I have an example of uninvolved cortex and medulla from the inferior pole. So I would submit that. Now after I cut this, if I determine it's too thick, which this one looks decently thin on this side and maybe a little thick on the other. There's several ways to approach trimming this. You can hold your forceps and hold the specimen up and then trim that way. That's one way. Another way is kind of leaving the specimen flat and then trimming a little excess that way. Or in certain circumstances, you can use scissors to trim. So now I have my uninvolved. The next uninvolved section that I want to get is my uninvolved renal pelvis and renal sinus fat. And please be clear in your cassette summaries to make sure that you are including both terms, renal pelvis and renal sinus fat, so that I know that you are taking representative sections of both of those very important structures. So I'm going ahead and taking another section, and this one again, a little bit thick, right? We want our sections about 0.3 to 0.4. You can see it's kind of thin over here and a little thick on this side, and perhaps decently thin on this end. So what I'm gonna do is lay the specimen flat, take my blade and gently trim the excess tissue. Remember, we want our edges to be pretty and smooth. We don't want to have jagged edges anywhere so that it looks nice for the pathologist. Okay. All right. Double check. Looks pretty good now. So I have my urothelial mucosa here. I have underlying adipose tissue, which is part of my renal sinus fat. I have a nice section with medulla and cortex. So that will be another uninvolved section. All right. And then I will go ahead and start taking my important tumor sections. So like I previously mentioned, we want to get a nice section of tumor to that renal sinus fat. Again, I just want to emphasize that after you serially section your mass, you need to measure it in 3 dimensions. Measure the distance to the capsule, the closest approach, and then the distance to Gerota's fascia. So I know I'm cutting over here. You want to make sure you do that. Examine all aspects of the mass before taking your sections, ensuring that your measurements are accurate when you're getting your approaches to surrounding structures. So please be careful as you are doing those measurements, as you are doing those cuts. Okay, so I am going to go ahead and sample right here because it looks like it's really approaching that renal sinus fat and urothelial mucosa here. Remember, renal sinus fat invasion is associated with a poorer prognosis, as is perinephric fat invasion. However, it is thought that perhaps renal sinus fat invasion is a poorer prognosis than perinephric. So it is important to document which fat the tumor is invading and be specific in your descriptions. So now I have my tumor in relationship to my renal sinus fat. And again, thickness wise, I think we're doing okay. Got a little bit of a thicker area over here. So I'm gonna go ahead and trim, make my edges look nice. And let's see which part is thick. Okay, if you're unsure when you're looking at your specimen, I know I've talked about this in our clinical correlations laboratory quite a bit, but you can just take your ruler, okay? So this is about 0.3, 0.4. It's bordering on a little thick, so just for, it looks okay on this end. So hopefully, you know, you'll start to kind of memorize what that thickness looks like in your mind so that you don't need to use the ruler anymore. So I think I'm gonna actually just take my blade, and it's really just this little area over here that's a little thick, and I'm just trimming off a little bit. And hopefully you can appreciate as well the size of the tissue that I am creating. Not only the thickness is what I'm talking about, but also just overall dimensions. I'm not putting in a tiny strip of tissue. I have a nice square of tissue that will fill the cassette. It will give the pathologist abundant information to look at under the microscope, and will give them a great image. So remember, we don't want to put in just tiny little strips of tissue. We want the pathologist to see a nice amount of information, give them relationships and structures. I'm just moving my tissue here so you can see it. Actually, maybe I'll move it over here. We have our hilar structure margins, our uninvolved inferior pole, our uninvolved renal pelvis with renal sinus fat, our tumor in relationship to renal pelvis and renal sinus fat. And remember, you want to do 1 per centimeter of the tumor. And you want to get variegated areas, so different looking areas of the tumor. So now what I'm gonna do is get my tumor to Gerota's fascia. So let's say it was closest over on this side. So you have to use ergonomics, right, and move the specimen so that you can cut the best. Okay, so as you can see, I've kind of left it a little bookend so that I can maintain some orientation. Okay, all right. So as you can see on this end, it's approaching the capsule. And so what I will do is my tumor to Gerota's fascia, and then I will get tumor to capsule. So I'm gonna go ahead and we'll say that some of this bleeding ink over here is my mass, right? And then we'll get it in relationship to Gerota's fascia. So sometimes the adipose tissue is really adherent and it doesn't move around as much. Other times it can be a little looser like this. So either way, even if it is loosely attached, like in this situation, you're still gonna want to get a section in relationship. And all you're gonna do then, right, is cut your tissue, and it's a little wet, so I'm actually gonna dry it a little because it's moving around quite a bit on me. So I wanna be safe and not cut myself or damage the tissue in any way. All right. So I am going to cut Actually, I'm going to switch to my sharp blade. Okay, we'll take the section from here. Okay, and then I want to get my Gerota's fascia. So there, I just cut that little strip with it. That's right next to it. And just hold, please. Okay, so got my tumor in relationship to my Gerota's fascia. I know that this ink is kind of bleeding everywhere, but hopefully you can get the picture. So something like that. Okay, so then I have tumor in relationship to that Gerota's fascia. Of course, you'd want to get that closest approach to that structure. And then I like this right here. I've got tumor in relationship to the capsule, so I can actually just cut like this. Change my plane a little bit. And now I've got my tumor with its closest approach to the capsule. Check our size here, a little thick, see? Hopefully you can appreciate, a little thick on that side. So what I'm going to do is trim. You want to trim on the opposite side from what you're going to submit into the cassette. So you don't want to trim the tumor away, right? You want to keep your relationships. Again, clean, pretty edges. Okay, and our tumor 2 capsule. Okay, so you want to make sure you get additional sections, 1 per centimeter of uninvolved. You can get uninvolved of your Gerota's fascia as well with perinephric fat. You want to examine your hilum for lymph nodes. In this particular case, there are actually several lymph nodes housed within this adipose tissue. In the human specimen, it is not extremely common to receive hilar lymph nodes, but you should still section through the hilar fat. So again, remember there's 3 terms when describing the fat with the kidney. There's the renal sinus fat, the perinephric fat surrounding the kidney, and then this fat kind of housed within the hilar structures. Like here you can still see that renal artery. So I would call that hilar fat or perirenal fat. Just be specific, check with your pathologist with what nomenclature they would like you to use. And again, get variegated areas of the tumor. I would probably sample again over here. I left this a little intact so that I could also get that angle of the tumor in relationship to that renal pelvis. So can even take a straight section actually. And this one I'll probably have to trim on the bench instead of as I cut it. As you can see, it's pretty thick. So again, just kind of lay it down, determine what side you want to go in the cassette. I want the side that is over here with my tumor and renal sinus fat. I want that to go down in the cassette, so then I will trim the opposite side. Let's see, I haven't done this way in a minute. I can hold it up and cut down. That's one way to trim it. Again, or you can go back, leave it flat. Okay, so again, nice size. Think about the size of a postage stamp, the thickness of about a nickel, a dime to a nickel. Oh, and it's a little thick still in that spot, so I'm gonna go back and trim again. So this ensures that the specimen is able to properly fix by cutting at the appropriate thickness. It ensures that there's not marks left on the tissue from the cassette being closed on it and being too thick. And you also, size-wise, don't want to make it too big because you want to ensure that there's an adequate rim of paraffin that's able to be infiltrated and put into the mold so that the tissue can then be cut well on the microtome. So then that would go in the cassette. Thank you so much for watching this video. I look forward to going over this prosection with you in person in lab. And as always, please let me know if you have any questions.